Elliott, first of all, thank you for a great grand rounds.
My
Absolutely spectacular, and presented it in a way that, well, you have a gift for taking the complex and explaining it in a way that we can stay along with and get these concepts. So, but what I want to do now is really talk a little bit more about you. And so you and I worked together basically as fellows, and then we were at Emory. But take me your journey beyond Emory. Emory was a great place,
Yeah.
But since then, tell me what you've been doing.
Well, spent almost 20 years in Atlanta at Emory and Georgia Tech, and in 2010 came up to Boston, where I have been serving as chair of surgery at Beth Israel Deaconess Medical Center. It's a very large department. We have over 80 clinical surgeons employed within the department, as well as another 50 PhD research faculty. So in total, somewhere on the order of 130 to 150 members of the Harvard Medical School faculty. There are 13 divisions within the Department of Surgery, and as a Canadian, I tell people it's more of a confederation than it is of a union. It's a way of bringing a lot of programs together, but currently the department continues to have neurosurgery, ophthalmology, ENT, urology, as all component members of sort of surgery. We also have major focus on education and research in addition to patient care, and so currently have about $26 million in research grants. Wow. We have a large clinical research program as well as translational research program, and have about 100 residents and fellows in a number of different programs, from general surgery to advanced fellowships in plastic surgery, vascular surgery. So it's a wonderful vascular surgery group with a long heritage of important contributions in vascular surgery, and it's wonderful to be a member and a partner in that group and to continue to be active in vascular surgery. But as you know, in your current leadership position as well, it's interesting when you start to have challenges and opportunities outside of your home department of vascular surgery. A lot of life is sort of looking at problems through other people's lenses. A lot of really interesting innovations that you've been a part of and others are really interdisciplinary and cross-disciplinary innovations. Laparoscopy was the collaboration between general surgeons and gynecologists. The world of endovascular aneurysm repair was collaborations between interventional radiologists and vascular surgeons. So it really is interesting, as you've done throughout your career, to really sort of see the experiments that a variety of different clinical disciplines within and outside of surgery are participating in, and then see opportunities where you sort of bring groups together.
Yeah, I mean, you've done a fantastic job, and congratulations. But you span beyond just the surgical disciplines, and that's really what I want to pick your brain a little bit. I'm going to tell you about a new initiative here, and we announced this idea of, it's called NMed, a new medical school concept, engineering medicine. And this is being done in collaboration with Texas A&M. As you know, they're a huge engineering school. And so beginning next year, all our MD PhD students who have a degree in one of the engineering specialties are going to be tracked down to Methodist. So about 40 engineers going into medicine will be here. A lot of the A&M faculty will be down here. And so we're beginning this journey of integrating a clinical operation with the guys who I think solve our problems, and those are the engineers. Right. And so you have lived that life. I mean, you're probably the best example in our specialty of someone who walks both sides of that platform. Just give me your thoughts on it and how we should evolve this. Maybe you should be an advisor of how this evolves.
No, I think that's a absolutely fantastic initiative. And life is problem solving. It's a team sport. Actually, life is about problem finding and problem solving. Sometimes we sort of underemphasize the importance of problem finding, right? Because the problems are all around us, but it's easy to sort of go through life without your eyes wide open. Helping engineers and non-engineers in the field of medicine really identify problems and then sort of forming teams that are interdisciplinary. When everybody around the table comes from the same background, the solutions people arrive at are pretty predictable and fairly mundane. When people come from very different backgrounds, that's sort of when the opportunity to close these ingenuity gaps arise. So in our environment, clearly there are a lot of great engineering programs, in Boston, and there's been a long tradition of cross-collaboration between Harvard and MIT. A number of examples of those programs where I'm on the faculty are the Wyss Institute for Biologically Inspired Engineering. That was an institute at Harvard that was founded by Hans-Jörg Wyss, who was the founder of Synthes. He's donated $250 million. That's an environment that's brought in engineers, scientists, clinicians, and actually a large number of individuals who spent their career in industry, understanding some of the challenges, because we tend to be in our own siloed environments, and bringing that expertise back into the university. The focus of that institute is to dramatically accelerate translation out of the academic laboratories and into the setting of patient care. So the focus there is on entrepreneurship, on innovation, on startups. Actually, most of the outside funding for the Wyss Institute comes from the DoD, more than it does from NIH. And the focus, the metric of success, is really startups and spin-offs. HST has been a more traditional environment for bringing engineers and clinicians together. In our department, we've had a number of different initiatives where we've tried to sort of cross this divide. We've brought people from industry into our department in a Center for Drug Discovery, individuals who've been leaders in drug discovery and chemistry and pharma, because many either clinician investigators or PhD investigators are fundamentally interested in drug development or device development, but if they haven't spent time in pharma or don't have the connections, can use some guidance in terms of how far to push in one direction, or where the data package needs to be stronger in another, when it's time to sort of spin it out or hold it back in. It's not about another line on a CV, it's really about having an impact on the life of a patient. Another strategy that we've done just this year is a program we call Harvard SPIN, Surgical Program and Innovation, and that's actually directed at current existing surgical residents in our program. The vast majority of surgical residents don't have an engineering background. There are a few that do, maybe as an undergrad, and an occasional MD PhD student will have, but most don't. And so the question is, how do you lower the barrier for engagement of clinicians, of surgical residents, in this process of problem finding and problem solving? So this is a program that incorporates 15 residents from the PGY 2 through the PGY 4 year. It meets once a month for 5 months, beginning in February and extending to this June. There's a website that you can look at the program. The program initially started with a mini hackathon. So hackathons are when you're hacking things. So trying to solve a problem, we think about it in the context of computer code. But our first hackathon was gave a problem to the surgical residents about designing a better chest tube, hacking the chest tube. It's interesting because when you then ask residents, so what's this problem, with chest tubes? Some said, well, we don't have a chest tube kit, so we actually spend a lot of time running around collecting everything. Others talked about the obese patient, the patient with a very high BMI, and concerns about potentially injuring themselves and putting in a chest tube, or how do you facilitate it? Other problems we gave them was, what happens if you're in a low resource environment where you don't have any don't have any gloves? How would you put in a chest tube if you didn't have any gloves? Or if the patients had a very high, incidence of HIV, positive status. When you create these constraints, or if you were on a Mars mission and you had to spend 2 years in space, and you needed to develop a chest tube kit for use on the space station or in a Mars mission, how would that sort of change your thoughts about the development of a chest tube? So this mini hackathon was to give residents, we broke them up into teams of 3, so there are 5 teams of 3, challenge them to sort of try to hack it, think about sort of how you would prototype it, and it was all really within a very short time period of a 60 or 90 minute block. The next sessions are focused on computer-aided design. Sessions after that on 3D printing and prototyping. Again, just to provide them with skill sets. I think 10 or 20 years from now, that's all going to be anachronistic, because now we're in an era where our children tell us, Mom, this is how Twitter works, from Dad. 20 years from now, kids are going to say, why are you going to the store to buy this? Let me 3D print it for you. So, but again, I think in the interim, it's providing residents with some skills, but also sort of lowering the barriers that may exist, whether it's practical barriers or conceptual barriers, to sort of engaging with people who come from very, very different disciplines, and actually to sort of promote the notion that the problems are around us, and we can get very focused as surgeons on learning our algorithms, learning the clinical decision making, being compassionate, caring, outstanding master surgeons, which is really first and foremost. But I think whether you're training to be a surgeon at Methodist or in Boston or elsewhere around the country, we're trying to produce the future leaders in American medicine who solve the problems that currently face us today. So I think trying to do a better job for both engineers as well as for those who don't come from an engineering background to really sort of be better engaged problem finders and problem solvers, I think is an important component. It's not, I guess what I would say is we talk in residency training about competencies, core competencies, professionalism, core medical knowledge, understanding system level change. The missing core competency is creativity and innovation. I think that that's really a critical component for thinking about the next generation of surgical education or medical education in general.
Well stated. Can't really add to that. So let me change tacks and talk a little bit about our fellowship and our time at Emory, both as fellows and faculty.
Yeah.
I want to talk to you about Bob Smith, and just I know from a personal standpoint, and I'm going to be able to deliver that to him, what it meant to me. Can you say a little bit about your time at Emory and Bob's role and who you are today?
Yeah, I've had, I think both of us have had, the good fortune of having a lot of wonderful mentors in our career, and I think we continue to have mentors. But Bob was in a very unique category and continues to be in a unique category. As that individual who was a master surgeon, a caring, compassionate clinician, was somebody who could always solve problems with equanimity and grace. Even the most challenging problems that would otherwise generate high levels of emotion, Bob was always able to approach it in a manner where everyone around the table, could approach it in a way where the best solution was identified. I think I do, and I'm sure you do, when we're faced in a difficult situation, probably continue to say to ourselves, how would Bob handle this problem? And I think when we think about that, the first thing we would do is say to ourselves, okay, take a deep breath, don't send that email, and really try to put yourself in the other person's shoes. I think we all try to aspire to be good leaders and to surround ourselves by good leaders. And I think Bob had the unique capacity to ensure that everybody had a voice, that he heard what people had to say and listened very deeply, He could articulate the criteria for making a decision. Everybody understood it, and as a consequence, always respected the decisions that he made. He really surrounded himself by outstanding individuals. He brought out the best in people. He inspired us to work a little bit harder every day, try a little bit harder, and to be fundamentally, at the end of the day, to be a good person. I think Bob, demonstrated, as well or better than anybody I've ever met in medicine, that it's all about a good heart, and everything else follows.
Thank you very much. Great having you. Appreciate it. Thank
Good.
you.
Thank you.